Namaskar. This talk is about molecular cytogenetics. Cytogenetics is traditionally described as analysis of chromosomes. Chromosomal disorders usually are associated with significant neurodevelopmental disabilities, and hence prevention of these disorders by prenatal diagnosis is very important. Karyotyping was the first genetic test which became available for analysis of patients with disabilities or mental retardation. The exact number of chromosomes was identified by Geo and Levin in 1956. And since then, the method of karyotyping or studying chromosomes from peripheral blood became easily possible. Chromosomes are beauty by themselves, and it may be really important reason or one of the reasons for anybody to fall in love with genetics. The various techniques evolved for chromosomal analysis, and the resolution of these techniques is different. The way it looks at the genome is varies, and hence it is very important for everyone to understand the principles of various techniques for chromosomal analysis and to understand when to order which type of test and what are the advantages as well as what are the limitations of each particular test. Chromosomes, though we see as colored bodies by staining, basically it's a molecule of DNA. And DNA is a sort of series of adenine, guanine, cytosine, and methionine nucleotides, and they are wound compactly. So if you want to study chromosomes, you can study them not only by painting with GMSA color or GMSA stain, but also by analyzing a sequence of those ATGC bases and study them at various resolution. When we think of chromosomes, usually we think of abnormalities of number or structure of chromosomes. Now, very minute abnormalities of chromosomes are available, can be detected by various techniques, and these techniques use DNA-based studies, and because the DNA sequences of each region of chromosome are unique, and that's why you can look for them and see if a copy of that particular sequence or chromosomal part is deleted or duplicated. And these submicroscopic abnormalities of deletions and duplications of chromosomal regions are called copy number variations. And if the resolution still improves, then practically we can study each and every nucleotide of a particular gene or DNA segment. And these tests are usually used for diagnosis of mutations in monogenic disorders. So marriage between DNA-based technology and chromosomes, or sort of using DNA-based technology where A anneals with T and G with C. This complementary hybridization technique is the principle, and when we use this principle for study of chromosomes, it is called molecular cytogenetics. The genetic disorders, as I said, we have described into different disorders, but basically it is a continuum, and then the techniques used for this diagnosis of disorders vary. Like for monogenic disorders, we usually use sequencing and Sanger sequencing or next generation sequencing. And for chromosomal disorders, we use traditional karyotyping or modern molecular cytogenetic techniques. So let us see how these modern cytogenetic techniques help us. When we see a chromosome, then it may be, depending on what phase of mitosis it is, you can see the number of bands on each chromosome keep on increasing. So earlier, towards prophase, the number of bands are more, and hence the resolution is more. But when whatever may be the resolution, at karyotyping level, even the smallest band is missing or duplicated, then at least 10 million base pairs are duplicated or deleted. So the resolution of traditional karyotyping is very poor. But that was the only way to look at the whole genome in one go. So every case with intellectual disability still needs a chromosome analysis, and it may be a karyotyping because of the less cost for this particular technique. And here you can see that the child with some malformations like polydactyly and developmental disability has some extra material on chromosome 13, and we don't know what it is originating from unless we did karyotype of the mother, and mother showed that there is inversion of chromosome 13, and then she is at a risk of having another child with developmental disability or such chromosomal imbalance, and hence prenatal diagnosis could be done, and during next pregnancy there was deletion of chromosome 13 and the imbalance was different. So this is routinely done, and it should be done for every case with mental retardation, developmental disability. This is the minimum test which must be done. But this type of traditional cytogenetic technique has many limitations. So basically, it needs live cells. It is technically demanding. Resolution is mainly low, but it can detect balance rearrangements as well as you can visually look at the region which is extra and where it is attached or from where it is deleted. But always a need was felt for a higher level of resolution, and techniques for looking for high resolution study of chromosomes were always sought for. This led to the one technique which is called fluorescence in situ hybridization or FISH technique. And here what you can see that here is a case with a small deletion on chromosome 5p, which is seen in traditional karyotyping. But you see another child, we thought that he also has chromosomal abnormality because of facial dysmorphism, but karyotype at a higher level of resolution was also normal. So we thought that he could be having deletion of 4p, and hence specifically FISH probes for chromosome 4p were used. And you can see the fluorescent signal on 4p on one chromosome 4 is seen, and on other chromosome 4 it is missing, suggesting that there is a 4p deletion. However, to use and order the test, one has to have some clinical clue to decide which type of which chromosomal region which you are expecting to be deleted. And it may not be able to do identify tandem duplications. So the advantage of FISH technology is resolution, increase high resolution, very small abnormalities which cannot be detected by traditional karyotyping can be detected by FISH. The other advantage is it can be done on even interphase nuclei. And these, because they can be seen in large numbers, so if you expect that there will be very low level mosaicism, then you can look for do FISH and look for count thousands of interphase nuclei to look for low level of mosaicism. Like in this particular child, there was patchy pigmentary lesions, suggested that there may be chromosomal mosaicism. In addition, she has polydactyly, and that is why the karyotype showed trisomy 13 in small number of cases, and FISH could be done to confirm that the trisomy 13 is really present. The use of clinically FISH in clinical genetics is, as I said, very high resolution, low level of mosaicism, and thirdly, very quick results. So for prenatal cases, like in this case, the duodenal atresia was detected, and 30% of prenatally detected duodenal atresia have trisomy 21. So immediately you can take amniotic fluid, and within 2-3 days you get the results of FISH, whether there is trisomy 13 or not. And this can be helpful in clinical decision making. The other important use of FISH can be sometimes complementary. You can see this family with one child with developmental disability and some abortions, and you can see the karyotype shows almost whole chromosome 15 attached to the chromosome 10. But we were wondering if small part of chromosome 15 is deleted or not. So there is a small region, Prader-Willi-Engelmann region near centromere, and we took probes for that region, which showed that there was a deletion of small part of centromeric region as well as the Engelmann, Prader-Willi-Engelmann region nearby. And hence the child has that particular disorder. So now this story ended because parents did not get their karyotype done, which was advised. And then after a few years, another family came, and this family had one spontaneous abortion, and wife was pregnant again 20 weeks. So this family, on taking family history, found to be related to the girl who had that deletion on chromosome 15 region. And hence we told that her mother may be carrier of some balance rearrangement because she also had recurrent abortions, and her brother, the husband in this case, may be carrier of the same rearrangement, and his karyotype from blood was done. We showed that he has that translocated chromosome 10, derivative chromosome 10. In addition, he has a small part of chromosome 13, which was missing in that girl who had developmental disability. So naturally now his wife who was pregnant needs amniocentesis to look at the chromosomal analysis of this particular baby in the womb. And here we could see that there were only one copy of centromere of chromosome 15 and the pericentromeric Prader-Willi-Engelmann region, indicating that the fetus also had the same unbalanced karyotype and the small part of chromosome 15 missing. So this stresses that how a fish technique can be used for in a complementary fashion to the traditional karyotyping, and also stresses the need of taking family history in detail. The other technique, which is also molecular cytogenetic technique, is called QF-PCR or quantitative fluorescent PCR. Here, what is taken there? There are some regions in the genome on some each chromosome where there are repeats, small sequences are repeated again and again. So somebody may have 5 copies of that repeat, somebody may have 3, somebody may have 10. So naturally, the size of this particular region will vary, and these type of variations we can identify and know whether there are 2 copies of a particular chromosome or 3 copies. So if you take such polymorphic markers on chromosome 21, 13, 18 and make a set of those particular PCR reactions, then you can do a prenatal diagnosis with a very rapidly, and even it is faster than fish-based testing. So if you take amniotic fluid, and in addition to these 2, if you see there are 3 markers um, uh, which can be seen on the electrophoresis as shown on the left side corner, and also it can be seen in an equipment called fragment size analyzer, where you can see 3 peaks for chromosome 21 and there are 2 peaks for chromosome 13. So if you take 3 markers on chromosome 21 at different regions, and if all 3 of them show 3 peaks, it means that the fetus has trisomy of that particular chromosome, trisomy 21 in this case. So this is very frequently used because of its speed, especially for prenatal diagnosis. Another molecular cytogenetic technique is multiplex ligation probe amplification. And the principle is that other than doing only 1 or 2 PCR reactions, it can combine together multiple 20, 30 regions can be evaluated, interrogated in one go by multiplexing the PCR. And for multiplexing, what they have done, that the primers on each side for every reaction are the same, and hence that particular PCR reaction can amplify multiple reactions, multiple regions in one go. And for each region there are specific probes, and the sequence here, it is called stuffer sequence, which changes in every for every marker, so that what you can get are multiple sizes of PCR fragments, which can be seen as on fragment size analysis, and then you can compare whether there are the ratio is normal or ratio is abnormal as compared to the normal. This technique as a very wonderful principle which you can see as on the video on the MRC website. Uh, Here the same results are shown for the same patient. So this yellow arrow shows upper panel shows for the patient where the size of that particular peak is less as compared to the normal, indicating that this particular child has only one copy of segment of chromosome 5p, meaning that there is deletion on chromosome, um, uh, that particular chromosome 4p, as we have seen in fish. So the advantage over fish is that you can at a time look at all ends of chromosome in one go, and 1p, 1q, 2p, 2q, and so on. So naturally, this is a multi-targeted as compared to fish, and hence no clinical diagnosis is needed. Without clinical diagnosis or clinical clue, you can go for this particular technique. And hence, in addition to the probe set for ends of chromosome, the probe sets for common microdeletion syndromes have also been made. And these are at different places. And what we found that using these MLPA probe sets, the diagnostic yield for intellectual disability is about 9 to 10%. This particular child, the picture shows long pear-shaped nose, and this is characteristic of 22q microdeletion. So if you have such a clinical diagnosis, then you can go ahead with fish. But if you do such multi-targeted testing, then the particular region will be covered. And also, if you do not have any clinical clue, then also probably you can get correct diagnosis. Because for those who have seen a patient, then their clinical diagnosis may be easy or possible. Like you can see so many children with Williams syndrome, and probably once I see so many children, I would be able to diagnose Williams syndrome clinically very easily. But for many rare disorders, clinical diagnosis may not be easy unless you see it frequently. Like this for Smith-Magenis syndrome, you can see the configuration of upper and lower lips is very characteristic, and this may be possible once you see many patients with these disorders. But if you do not have any clinical clue, and then also probably it will give good diagnostic yield. In addition, at a time, if there are two abnormalities together, like the lower panel shows, there is a deletion on chromosome 6p and duplication on chromosome 8q, and such type of rearrangements where there is two segments are involved are usually associated with balanced rearrangement in the parents, and hence increased possibility of risk of recurrence. These all we saw that there, though even if multi-targeted, at a time MLPA can look at only a fixed number of regions. On the other hand, if there is a now technique called microarray based cytogenetic analysis, where there are lakhs and lakhs of probes, like in the 750K chip, there are about 5.5 lakh unique probes, as well as about 2 lakh SNP probes, which are spaced all over genome. And hence, we can look at multiple regions without any clinical clue, and very small 100 kb deletions or duplications anywhere in the genome can be picked up. So if you compare karyotype to a map of India where Lucknow is seen as a dot, then cytogenetic microarray can be considered to be as a Google Maps, where not only this Lucknow, but you can see even our institute SGPGI hospital in the picture. So this is the high resolution karyotype. Cytogenetic microarray is a very high resolution karyotype, and it gives a diagnostic yield around 20% as per most of the studies shown worldwide. And hence, it is the first tier of test for children with developmental disabilities, intellectual disability, or autism. This is a representative case where the child has microcephaly, intellectual disability, as well as ectrodactyly, you can see in the feet. The 7 million base pair deletion was detected on chromosome 7, and this is seen as the loss of that probes, only one copy, and you can see the ratio here in the deleted region is shown by the red bar, and below that you can see that this region probes, there are so many probes there, you can see thousands of probes, and they have only one copy indicating that there is deletion. Now, what do you get more information by microarray? You also get information that which are the genes in this region. And also you can compare the deletions and their locations with other published report. So these are the various cases published by different people on the same deleted region, and these are the genes involved present in this particular region. So there is a gene for ectrodactyly, gene for deafness, and if you see that depending on the size of deletion, many small deletions had only ectrodactyly, while as the bigger deletions had ectrodactyly as well as intellectual disability, and larger deletions including our patient had ectrodactyly, deafness, intellectual disability, and microcephaly. So some genotype phenotype correlation can be made, and especially this is very important if such deletion is detected by prenatal ultrasonography, and we want to tell the family what would be the likely outcome. Secondly, if even if you do not have any clinical clue, then also you can get a correct diagnosis. Like this particular girl, she does not have a specific facial phenotype of 22q deletion, and she has post-axial polydactyly, does not have a cardiac defect, and hence I did not suspect 22q deletion in this case, but microarray showed that there was 3 MB deletion in the region for 22q11 deletion, common microdeletion syndrome. So this is the power of microarray based genomic analysis. But when we see these deletions, duplications, then in normal individuals also you get some deletions, duplications, and then you have to look into these various databases as well as published literature in PubMed to find out whether there are any similar type of deletions or duplications are reported in the literature, so that you can come to conclusion which one of the results which you have got is really causative or pathogenic in nature. There are various cytogenetic databases also. Decipher is one important, where there is a list of cases with various deletions, duplications reported by various laboratories. So when you see such copy number variations, so there may be some which are reported in the literature of normal variants in normal population, and these are called benign. There are ones which are reported in patients many times, and they are known to be associated or causative. So these are pathogenic and clinically very important. But in addition to that, many times we get many variants which are of unknown significance. They are not very small, or they may be large also sometimes, and they may contain some important genes but not published in the literature, and so many. So such variations of unknown significance are very challenging for making interpretation and counseling, especially in prenatal results. But because of this power and high diagnostic yield, American College of Medical Genetics and Genomics says that cytogenetic microarray should be the first year test for any children with multiple anomalies, syndromic or non-syndromic developmental disability, autism spectrum disorder, and also they say that for any prenatal sample taken for any other indication, that sample can be processed to look for these copy number variations, and uh, uh, some of them may be present without any ultrasonographic abnormalities in the fetus. The challenges in the interpretation of data, as I said, Sometimes there are many multiple copy number variations, and we really may be difficult to interpret whether it is causative or not. These databases, which I already told, that you look at these databases and then you read about those published literature, look at their photographs of those patients, and then you can call your patient again and then look at those features to really decide whether this your patient has similar physical or phenotypic features or not. And such type of detailed phenotyping after getting the results is called reverse phenotyping, and it's a very important responsibility of clinician for making the lab help in making interpretation about variations identified by microarray. The example of such deep phenotyping I am showing with this particular girl with disability was identified to have deletion on chromosome 17q. This particular region has NOG gene, NOG gene, which causes synphalangium. That means the phalanges are fused. So this picture shows the fused phalanges in another patient, not this particular. In fact, this particular girl, we had not noted that she had synphalangium, but when we got the report, by that time the girl was not alive. And we had to look at her photograph, and you can see the photograph shows that she does not have these creases on the interphalangeal joint, suggesting that probably she did have this type of synphalangium supporting supporting the causative nature of this particular uh, copy number variation. These are the other patients reported with the same abnormality, and you can look at the face and note the big nose as seen in our patient. So the comparison of phenotype after getting report is very important. Another case with intellectual disability and deletion on chromosome 14q. So very non-specific phenotypic abnormalities, some specific, some vague dysmorphic features. But when you see other patients reported with the same deletion, you can see, note the similarities like bulbous nose and tented upper lip, like inverted V-shaped upper lip, large ears. So this type of clinical evaluation after the reports is reverse phenotyping and is very, very useful. So basically, microarray is very useful as a first year investigations for intellectual disability, but it's important also sometimes it can be helpful in evaluation of abnormalities detected by traditional karyotyping. This particular child had extra material on chromosome 12, and we did not know what it is from. So microarray showed that there was duplication of the 12p. That means the same part was duplicated tandemly, and we got the origin of this extra material on chromosome 12 by microarray. Prenatally, it becomes very, very important because in prenatal diagnosis, we identified such a marker chromosome in a amniotic fluid. Ultrasound did not show any abnormalities. Parents' karyotypes were normal. Microarray showed that there were 5 copies of this small centromeric region of chromosome 15. And naturally, that must be the source for this extra marker chromosome. This has derived from the centromeric region of chromosome 15. Now the question is that because there is a very close region which has a Prader-Willi-Engelmann syndrome region, and hence we did fish for Prader-Willi-Engelmann syndrome region for this particular patient, and we see that only centromeric signals are there on the marker chromosome, and there are only 2 copies of Prader-Willi-Engelmann region shown by pink colored signals, and there is no deletion or duplication of this region, indicating that the child is likely to have a normal phenotype without any abnormalities, because there are hardly any important genes in the duplicated marker chromosome. So baby was normal after 3 months and 1 year of age. So microarray has also helped in solving unsolved cases which were under follow-up. And you can see this child who had 9 MB loss and on chromosome 7 and 13 MB gain on chromosome 11. This was the pedigree, and this particular child there was multiple poor outcomes like neonatal days, holoprosencephaly, or cerebral palsy like things, and so on. So we also investigated another girl from the same family with developmental disability. She also had same similar type of involvement of the same chromosomes, but it was opposite, like deletion and duplication was interchanged. So this one baby had loss on chromosome 7 and the same region was duplicated in another child, and vice versa. So it means that the uh, their fathers through whom they were related, they may be carriers of some balance rearrangement, and hence we did fish for those regions. So you can see that there is exchange of material, like this is a normal 7, this is normal 11, and if there is translocation between 7 and 11, so what is happening, that there may be formed unbalanced gamete leading to trisomy or of the ends of chromosome 7 and monosomy of 11, or monosomy of 7 and trisomy of um, 7 accordingly. So this was confirmed by fish technique. So red color is the red color signal is for chromosome 11, and green color is for 7. So you can see one normal 11 with both green colors, centromeric and telomeric, while there is one green color, both green colors showing that is a normal chromosome 7, and there is exchange between two, so centromeric region and so you can see two chromosomes with green and red signals, so showing that these are exchanged, and there is suggestive confirming balanced translocation in the parent. So such type of families will have high risk of recurrence, and then they can be helped by prenatal diagnosis by FISH or microarray, or also now in this era they can be helped by pre-implantation genetic diagnosis. Uh, Such type of abnormalities can be very many, very interesting cases can be there, and you can find out deletion duplications, even if the balance is, karyotype showed that it was sort of looking balanced, but when we did microarray, there was small deletion in this particular case, and such type of cryptic or hidden imbalances at the breakpoints may not be detectable by traditional karyotyping. So etiological diagnosis is very important for genetic counseling, and risk of recurrence may vary from negligible to 50%, and prenatal reproductive options can be help to them. Lastly, very, very rarely, even this microarray can detect some etiologies for monogenic syndrome. So this was a case with typical Kalman syndrome with hypogonadism and also having ichthysis. So his hypogonadism was there, and because he had some extra features, so and his karyotype showed that there was an extra material on chromosome X. So we did microarray, which showed that the extra material on chromosome X was really material from Y. And because of translocation between Y to X, during that process, small part of chromosome at the end of chromosome X was deleted. And this was going through the gene, Kalman gene, which is gene for Kalman syndrome. And in addition, this deletion was also involving gene for ichthysis, and that's why he had ichthysis and some developmental disability. So such type of microdeletion was detected, which was disrupting. It's not really deleting, but some part of the gene, Kalman gene, was deleted, giving rise to Kalman syndrome. So the such type of interesting results can be there, and if you know the principle of particular test, then you can order appropriately in a cost-effective fashion, and then interpret the results properly. So here this again shows the same, the extra material on the chromosome X, which is because the P arm of X chromosome is larger, and this showed this particular deleted region. So this is the Calvin gene breakpoint, as well as whole STS gene for ectasis is deleted. Lastly, the time is not far. Now, whole genome sequencing can identify all these copy number variations as well as point mutations for single gene disorders. And even whole exome sequencing also can identify these structural rearrangements. So as this cost of these next generation sequencing based techniques is coming down, probably there will be this one test for all. You do exome sequencing or whole genome sequencing, and then look for chromosomal abnormalities, copy number variations, as well as monogenic disorders in one go. And that is the really then it would become very simple thing, and to decide which one test to be offered will depend only on the cost calculations for the family. Thank you very much.